Hello and welcome to the lecture on the trauma overview. After you complete this chapter and the related coursework, you will have an understanding of the basic concepts of energy and its effect on the human body, the general injury patterns associated with different types of impacts, falls, and penetrating trauma, and the basic applications of the laws of physics and on the assessment of trauma patients. You will begin to demonstrate critical thinking in making predictions of injuries and adjusting index of suspicion based on the analysis of evidence gathered in scene size-up simulations. Students will also understand some common injury patterns to major body systems. Under the National EMS Education Standard Competencies for Trauma, the general recommendation is that the student will be able to apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Regarding trauma overview, you'll understand pathophysiology, assessment, and management of the trauma patient, including trauma scoring, rapid transport and destination issues, and transport mode. Regarding multi-system trauma, you will recognize and manage multi-system trauma, as well as understand the pathophysiology, assessment, and management of both multi-system trauma and blast injuries. For people younger than 40 years of age, traumatic injury is the leading cause of death in the United States. Proper pre-hospital evaluation and care can do much to minimize suffering, long-term disability, and death from trauma. Trauma emergencies occur as a result of physical forces applied to the body. Medical emergencies occur from an illness or condition not caused by an outside force. Evaluation of the mechanism of injury for the trauma patient will provide you with an index of suspicion for different types of serious or life-threatening underlying injuries. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries. Energy and trauma. Traumatic injury occurs when the body's tissues are exposed to energy levels beyond their tolerance. The mechanism of injury is the way traumatic injuries occur. It describes the forces or energy transmission acting on the body that cause injury. The three concepts of energy are typically associated with injury: potential energy, kinetic energy, and work. Energy can be neither created nor destroyed, but can only be converted or transformed. Work is defined as force acting over a distance. Forces that bend, pull, or compress tissues beyond their inherent limits result in the work that causes injury. The work of a moving object is called kinetic energy. Kinetic energy reflects the relationship between mass or weight of an object and the velocity or speed at which it is traveling. According to the equation for kinetic energy, the energy that is available to cause injury doubles when an object's weight doubles, but quadruples when the speed doubles. Potential energy is the product of mass or weight, force of gravity, and height. It is mostly associated with the energy of falling objects. Different types of mechanisms of injury will produce many types of injuries. They will produce non-significant injuries, injury to an isolated body part, or a fall without loss of consciousness. They can also produce significant injuries. These include injury to more than one body system, called multi-system trauma, falls from heights, motor vehicle and motorcycle crashes, car versus pedestrian or bicycle or motorcycle, gunshot wounds, and stabbings. Blunt and penetrating trauma. Traumatic injuries can be divided into two separate categories: blunt trauma and penetrating trauma. Either type may occur from a variety of mechanisms of injury. It is important that the EMT consider unseen as well as visible obvious injuries with either type of trauma. Blunt trauma is a result of force to the body that causes injury without penetrating the soft tissue or internal organs and cavities. Penetrating trauma, on the other hand, causes injury by objects that primarily pierce and penetrate the surface of the body and cause damage to soft tissues, internal organs, and body cavities. Blunt trauma results from an object making contact with the body. Motor vehicle crashes and falls are the most common mechanisms of injury for blunt trauma. You need to be alert to skin discoloration and pain. These may be the only signs of blunt trauma on your patient, and you need to maintain a high index of suspicion for hidden injury. Motor vehicle collisions. Vehicular collisions or motor vehicle crashes are classified traditionally as frontal or head-on, rear end, lateral or T-bone, rollovers, and rotational or spinning. The principal difference is the direction of the force of impact. A crash typically consists of 3 collisions. First of all, the car against the other object, a car, a tree, or whatever other object it may be. Damage to the car has an indirect effect on patient care. By assessing the vehicle that is crashed, you can often determine the mechanism of injury for your patient. The second part of the collision process is the passenger against the interior of the car. The kinetic energy produced by the passenger's mass and velocity is converted into the work of stopping his or her body. Common passenger injuries include lower extremity fractures, flail chest, and head trauma. I'll play this animation again. Pay attention to the collision type of the passenger against the interior of the car. The passenger's internal organs against the solid structures of the body is the third type of the collision process. Internal injuries may not be as obvious as external injuries, but they are often more life-threatening. Significant mechanisms of injury include the following findings: death of an occupant in the vehicle, severe deformity of the vehicle or intrusion into the vehicle, altered mental status, ejection from the vehicle. Frontal collisions. You need to evaluate the supplemental restraint system. Determine whether the passenger was restrained by a full and properly applied 3-point restraint. Determine whether the airbag was deployed. Seatbelts and airbags are effective in preventing a second collision inside the motor vehicle. Seatbelts may decrease the severity of the third collision. Airbags decrease the severity of deceleration injuries, and they also decrease injury to the chest, face, and head. Despite airbags, suspect injuries to extremities resulting from the second collision and internal organs resulting from the third collision. Children shorter than 4 feet, 9 inches should always ride in the rear seat of a vehicle. In a pickup truck or single-seated vehicle, the airbag should always be turned off. Remember that if the airbag did not inflate during the accident, it may deploy during the extrication process. Also remember, the supplemental restraint systems can cause harm whether they are used properly or improperly. Hip dislocations may result if seat belts are worn too low. Internal injuries can occur when the belt is worn too high, and lumbar spine fractures are also possible, particularly in the elderly. A great animation of a frontal collision. Rear-end collisions are known to cause whiplash-type injuries, particularly in absence of an appropriately placed headrest. As the body is propelled forward, the head and neck are left behind. The cervical spine and surrounding area may be injured. Acceleration-type injury to the brain is possible. Third collision of the brain with the skull causes this. Lateral impact collisions. Lateral or side impacts, commonly referred to as T-bone collisions, are a very common cause of death associated with motor vehicle crashes. A vehicle struck from the side is usually struck above its center of gravity, and it begins to rock away from the side of impact. This results in the passenger sustaining a lateral whiplash injury. If there is substantial intrusion into the passenger compartment, the EMT should suspect lateral chest and abdominal injuries on the side of impact, possible fractures of the lower extremities, pelvis, and ribs, and organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in motor vehicle crashes are a result of lateral collisions. Rollover crashes. Large trucks and SUVs are prone to rollovers because of their high center of gravity. Injury will depend on whether the passenger was restrained. The most common life-threatening event in a rollover is ejection or partial ejection of the passenger from the vehicle, and even when restrained, passengers may sustain severe injuries. Rotational collisions. Rotational collisions or spins are conceptually similar to rollovers. The rotation of the vehicle as it spins provides opportunities for the vehicle to strike objects such as utility poles. Vehicle versus pedestrian. The injuries are often graphic and apparent. There can also be serious unseen injuries to underlying body systems. You must maintain a high index of suspicion for unseen injuries, and you should determine vehicle speed, whether the patient was thrown through the air and at what distance, and whether the patient was struck or pulled under the vehicle. Evaluate the vehicle that struck the patient for structural damage, and ALS backup should be summoned for any patients who have or are thought to have sustained a significant mechanism of injury. Vehicle versus bicycle. Evaluate the mechanism of injury in much the same manner as vehicle versus pedestrian collisions. Also evaluate the damage to and position of the bicycle. If the patient was wearing a helmet, inspect it for damage, and presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise at the hospital. Spinal stabilization must be initiated and maintained during the encounter. Vehicle versus motorcycle. Protection is from the helmet. Helmets do not protect against severe cervical spine injury. Leather or abrasion-resistant clothing. Leather clothing will protect mostly against road abrasion, but offers no protection against blunt trauma from secondary impacts. Boots. And collisions usually occur against larger vehicles or stationary objects. When you are assessing the scene of a motorcycle crash, attention should be given to the deformity of the motorcycle, the site of the most damage, the distance of skid in the road, and the extent and location of deformity in the helmet. Head-on collisions. There are 4 types of motorcycle impacts that you need to be aware of. The first is head-on collisions. The motorcycle strikes another object and stops its forward motion while the rider continues his or her forward motion until stopped by an outside force. An angular collision. The motorcycle strikes an object or other vehicle at an angle so that the rider sustains direct crushing injuries to the lower extremities between the object and the motorcycle. Ejection. The rider will travel at high speed until stopped by a stationary object, another vehicle, or road drag. Controlled crash. A technique used to separate the rider from the body of the motorcycle and the object to be hit is referred to as laying the bike down. The next traumatic injury we're going to talk about in trauma overview is falls. The injury potential of a fall is related to the height from which the patient fell. The greater the height of the fall, the greater the potential for injury. A fall from more than 15 feet or 3 times the patient's height is considered significant. Internal injuries pose the greatest threat to life here. A patient who falls and lands on their feet may have less severe internal injuries because their legs may have absorbed much of the energy of the fall. However, they may also have serious injuries to the lower extremities and pelvic and spinal injuries. You should take the following factors into account: the height of the fall, the type of surface struck, the part of the body that hit first, followed by the path of energy displacement. And we'll watch this animation. The next trauma we're going to talk about is penetrating trauma. Penetrating trauma is the second leading cause of trauma death in the United States after blunt trauma. Low energy penetrating trauma may be caused accidentally by impalement or intentionally by a knife, ice pick, or other weapon. Many times it is difficult to determine entrance and exit wounds from projectiles in a pre-hospital setting. So you should determine the number of penetrating injuries and combine that information with the important things you already know about the potential pathway of penetrating projectiles. With low energy penetrations, injuries are caused by the sharp edges of the object moving through the body and are therefore close to the object's path. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. In medium and high velocity penetrating trauma, the path of the projectile, usually a bullet, may not be easy to predict. The bullet may flatten out, tumble, or even ricochet within the body before exiting. The path the projectile takes is referred to as a trajectory. Fragmentation will increase the damage. Cavitation can result in serious injury to internal organs distant to the actual path of the bullet. There are 2 types of cavitation. The first is temporary cavitation, and that is caused by the acceleration of the bullet and causes a stretching of the tissue. Permanent cavitation is caused by the bullet path and remains once the projectile has passed through the tissue. The relationship between distance and the severity of injury varies depending on the type of weapon involved, such as a rifle, pistol, or shotgun. Air resistance, often referred to as drag, slows the projectile, decreasing the depth and penetration and thus reducing damage to the tissues. The area that is damaged by medium and high velocity projectiles can be many times larger than the diameter of the projectile itself. This is one reason that exit wounds are often many times larger than entrance wounds. The energy available for a bullet to cause damage is more a function of its speed than its mass, and any information regarding the type of weapon that was used should be relayed to medical control. We're going to now watch these animations regarding medium and high velocity. Next is high velocity. So here we have a chart that talks about recognizing developing problems in trauma patients. So you can take this in a synopsis and look at the mechanism of injury, the signs and symptoms we see, and the index of suspicion for additional injuries. The next section we're going to discuss is blast injuries. Although most commonly associated with military conflict, blast injuries are also seen in civilian practice in mines, shipyards, chemical plants, and in association with terrorist activities. People who are injured in explosions may be injured by any of four different mechanisms: the primary blast, the secondary blast, the tertiary blast, or miscellaneous blast injuries. Primary blast injuries are due entirely to the blast itself. Secondary injuries are damage to the body, and it results from being struck by shrapnel and flying debris. Tertiary blast injuries is where the victim is hurled by the force of the explosion, and sometimes this is against a stationary object. And then miscellaneous blast injuries occur from such things as burns from hot gases or fires started by the blast, respiratory injury from inhaling toxic gases, and crush injuries from the collapse of buildings. Most patients who survive an explosion will have some combination of the four types of injury mentioned. The tissues that are at risk need to be discussed. Organs that contain air, such as the middle ear, the lung, the GI tract, these are the most susceptible to pressure change. The junction between tissues of different densities in exposed areas, such as the head and neck tissues, are prone to injury as well. The ear is most sensitive to blast injury, and the tympanic membrane evolved to detect minor changes in pressure and will rupture at pressures of 5 to 7 pounds per square inch above atmospheric pressure. Pulmonary blast injuries are defined as pulmonary trauma that results from short-range exposure to the detonation of explosives. Pneumothorax is a common injury and may require emergency decompression in the field. This requires a paramedic. Pulmonary edema may come on rapidly and cause major changes in the patient's condition. One of the most concerning pulmonary blast injuries is arterial air embolism, which occurs on alveolar disruption with subsequent air embolization into the pulmonary vasculature. It can produce disturbances in vision, changes in behavior, changes in state of consciousness, and a variety of other neurologic signs. Solid organs are relatively protected from shock wave injury, but may be injured by secondary missiles or a hurled body. Hollow organs may be injured by similar mechanisms, such as lung tissue. Neurologic injury and head trauma are the most common causes of death from blast injury. Subarachnoid and subdural hematomas are often seen, and bradycardia and hypotension are common symptoms that we see. Extremity injuries, including traumatic amputations, are very common. Multisystem trauma. Multisystem trauma involves more than one body system: head and spine, chest and abdomen, chest and multiple extremity. You must alert medical control and transport these patients rapidly. The golden principles of pre-hospital trauma care. We used to call this the golden hour. Your main priority is to ensure your safety, the safety of your crew, and the safety of the patient. You need to determine the need for additional personnel or equipment and evaluate the kinematics of the mechanism. Identify and manage life threats, then focus on your patient care. Assess and manage the airway. Ensure that basic shock therapy is completed, and consider use of a tourniquet for extremity amputations or severe bleeding. You should place the patient on a long backboard and transport this patient immediately to the appropriate facility. In most patients who experience multi-system trauma, definitive care will require surgical intervention, and your on-scene time must be limited to 10 minutes or less if at all possible. During transport, you should obtain a sample history and complete your secondary assessment. And consider ALS intercept and or air medical transport. Patient assessment consists of scene size up, primary assessment, history taking, secondary assessment, and reassessment. When you are caring for a patient who has experienced a significant mechanism of injury and the patient is considered to be in serious or critical condition, you should perform a rapid full body scan or rapid head-to-toe exam. You want to evaluate injuries to the head. You need to look at this area because disability and unseen injury to the brain may be occurring. Bleeding or swelling inside the skull is often considered life-threatening, and you need to include frequent neurologic exams in your assessment. Some of your patients will not have obvious signs or symptoms until minutes or hours after the injury has occurred. Injuries to the neck and throat. These are areas of serious or deadly injuries. For example, the trachea may be torn as a result of injury. Airway problems may result that could quickly become a serious life threat. And your assessment must include frequent physical exams looking for decap BTLS in the region of the neck. You should also assess for jugular vein distension and tracheal deviation. Decap BTLS stands for deformity, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. Swelling may prevent blood flow to the brain and cause injury to the central nervous system. A penetrating injury may result in an air embolus, and a crushing injury to the upper part of the neck may cause the cartilages of the upper airway and larynx to fracture. Chest injury. The chest, as we know, contains the heart, the lungs, and the large blood vessels, and there are many life-threatening injuries that occur to the chest. Broken ribs may hinder breathing. Bruising may occur to the heart and cause an irregular heartbeat. Large vessels of the heart may be torn inside the chest, and air may collect between the lung tissue and the chest wall, and this is known as a pneumothorax. A penetration or perforation of the integrity of the chest is called an open chest wound. If left untreated, shock and or death may result. It is imperative that you assess the chest region every 5 minutes. An assessment should always include decap BTLS, lung sounds, and chest rise and fall. Injuries to the abdomen. The abdomen contains vital organs that require a very high amount of blood flow to perform the functions necessary for life. The organs of the abdomen and retroperitoneum can be classified into two simple categories, solid and hollow. Solid organs include the liver, spleen, pancreas, and kidneys, and hollow organs include the stomach, large and small intestines, and urinary bladder. When injuries from trauma occur in this region of the body, serious and life-threatening problems may occur. Solid organs may tear, lacerate, or fracture, and this can cause serious bleeding into the abdomen. Hollow organs may rupture and leak acid-like digestive chemicals, and the patient may eventually develop a life-threatening infection. The rupture of large blood vessels can cause serious unseen bleeding, and you need to reassess the abdomen region using decap BTLS. Management, transport, and destination. The first part we want to talk about is scene time. Survival of critically injured trauma patients is time dependent. We need to limit our on-scene time to the minimum amount necessary to correct life-threatening injuries and package the patient. Realistically, our on-scene time for critically injured patients should be less than 10 minutes. The following criteria will help you identify a critically injured patient. They have had a dangerous mechanism of injury, they have a decreased level of consciousness, or there are any threats to airway, breathing, and circulation. Type of transport. Modes of transport ultimately come in one of two categories, ground or air. Ground EMS units are staffed by EMTs and paramedics, and air EMS units or critical care transport units are staffed by critical care nurses and paramedics. Destination selection. We're going to go back to that last slide. There are a couple more things I want to point out to you. The Association of Air Medical Services and Medevac Foundation International identify the following criteria for appropriate use of emergency air medical services for trauma patients. There is an extended period required to access or extricate a remote or trapped patient. The distance to the trauma center is more than 20 to 25 miles by ground. The patient needs ALS care, and there is no ALS-level ground ambulance services available within the reasonable frame time. Traffic conditions or hospital availability make it unlikely that the patient will get to a trauma center via ground ambulance within the ideal time frame. There are multiple trauma patients who will overwhelm resources at the nearby trauma centers. EMS systems require bringing a patient to the nearest hospital rather than bypassing facilities to go directly to a trauma center. This may add delay to receiving definitive surgical care. There is a mass casualty incident. These are all of the reasons why air medical might be appropriate. Now let's go to destination selection. It is important for you to be familiar with how the American College of Surgeons Committee on Trauma classifies trauma care. Trauma centers are classified into levels 1 through 4, with level 1 having the most resources, followed by levels 2, 3, and 4 respectively. A level 1 facility generally serves large cities or heavily populated areas. They provide every aspect of trauma care, and most level 1s are university-based teaching hospitals. Level 2s are located in less population-dense areas and provide initial definitive care. Level 3s provide assessment, resuscitation, emergency care, and stabilization, and they transfer patients to level 1 or 2 facilities when necessary. Kalispell Regional Medical Center is a level 3 trauma center. And a level 4 facility is typically found in remote outlying areas where no higher level of care is available, and they provide advanced trauma life support and transfer to a higher level trauma center. As you can see here, Table 22-2 provides key elements for trauma centers. It gives you a definition and some of the key elements of what is provided. This is a great synopsis for you to study by. Trauma centers are categorized as either adult trauma centers or pediatric trauma centers, but not necessarily both. Pediatric trauma centers are not nearly as common, and do not make the mistake of transporting a pediatric patient to an adult trauma center when you do have a pediatric trauma center available. At this time, we have no pediatric facilities specifically in Northwest Montana. The American College of Surgeons Committee on Trauma provides criteria for level 1 and 2 trauma patient classification. And as I said, you can see the tables 22.3 on the previous slide and in your book, and here's table 22.3. And a level 1 patient has a confirmed blood pressure of less than 90 millimeters of mercury at any time in adults, or has age-specific hypotension in children. They may have respiratory compromise, obstruction, and or intubation. They may need to receive blood to maintain vital signs at the emergency physician's discretion. They have a GCS score of less than or equal to 8 with mechanism attributed to trauma, or they have a gunshot wound to the abdomen, neck, or chest. Some special considerations. This is level 2 patient criteria here. And I'm not going to read each of these to you, but you can use these to help you identify why patients might need to go to a level 2 or be designated as a level 2 patient. Special considerations. You always need to remain calm. You should complete an organized assessment on any trauma or medical patient, correct any life-threatening injuries. By our motto, we should always do no harm, and never hesitate to contact ALS assistance or medical control for guidance. In summary of the trauma overview chapter, you need to determine the mechanism of injury as quickly as possible, and this will assist you in developing an index of suspicion for the seriousness of your patient's unseen injuries. 3 concepts of energy are typically associated with injury: potential energy, kinetic energy, and work. Traumatic injuries can be described as blunt or penetrating. Motor vehicle crashes are classified traditionally as frontal or head-on, lateral or T-bone, rear end, rotational or spin, and rollover. In every crash, there are always 3 collisions that occur: the vehicle against the object that it crashes with, the passenger against the inside of the vehicle, be it the restraint system or something else, and the passenger's internal organs against the solid structures of the body. The EMT should always maintain a high index of suspicion for serious injury in the patient who has been involved in a motor vehicle collision or a motor vehicle collision with significant damage to the vehicle, has fallen from a significant height, or who has sustained penetrating trauma. You should communicate your mechanism of injury findings in the written patient care report and verbally to hospital staff. This ensures that appropriate treatment for potential serious injuries continues for the patient at the hospital. People who are injured in explosions may have injuries that are classified as primary, secondary, tertiary, or miscellaneous. Patients who have sustained a significant MOI and are considered to be in serious or critical condition should receive a rapid full-body scan or a rapid head-to-toe exam. Any patient who has sustained a non-significant mechanism of injury should receive an assessment focused on their chief complaint. In caring for trauma victims, it requires you to have a solid understanding of the trauma system in the United States, and this includes transport time, destination, and selection of type of transport. As always, if you have questions, please bring them to your instructor for discussion with your classmates. Thank you.